Hi everyone, so today we're going to be talking about cerebrovascular disorders, demyelination, dementia, and degeneration. Now, this is a topic I struggled a lot with in third year, and so I strongly advise for you guys to take your time with it. Cerebrovascular disorders, also known as strokes, are medical emergencies when blood supply to the brain is cut off. Now, this may be due to ischemia, which is 85% of cases, or hemorrhages, i.e. bleeding, which is 15% of cases. The issue, of course, being that neurons are unable to regenerate, and so after 3 to 5 minutes, they will undergo necrosis. Now, global cerebral ischemia, also known as hypoxic encephalopathy, has four major etiologies: cardiac arrest, shock, chronic hypoxia, and hypoglycemia. The nerves are more sensitive than glial cells. We should note that down. And also, the pressure is less than 45 millimeters of mercury. The blood pressure is less than 45 millimeters of mercury. And clinical features may be mild, moderate, or severe. Mild results in the patient having transient confusion, but there is a prompt recovery. Moderate, most often in the watershed areas, which are the very ends between the anterior and middle cerebral arteries. These areas are highly vulnerable. And lastly, severe. The severe variation would result in the patient being in a vegetable state due to diffuse necrosis. Now, the most sensitive areas would be the neocortex, the hippocampus, and the Purkinje layer of the cerebellum. So here we'll discuss the morphology of global cerebral ischemic tissue. Now, in the acute stage, there will be red neuronal cell death change and neutrophilic infiltration. Subacute, you would see tissue necrosis, macrophages, and reactive gliosis. Lastly, you'll see gliosis and laminar necrosis in the chronic stage. Now, with focal ischemia as opposed to global cerebral ischemia, the whole brain is not affected, but in fact just specific foci or even just one region, one specific region. In focal ischemia, I would like to note that this occurs after 24 hours, but if it is less than 24 hours, we don't call this focal ischemia, but instead we call it a transient ischemic attack. The result would be fluid-filled cystic spaces with gliosis surrounding, and the morphology would be similar, of course, to global. Subtypes of focal ischemia include thrombotic, embolic, and lacunar. Now, with the thrombotic subtype, we have the rupture of the atherosclerotic plaque. Now, this occurs at the branch points, specifically the internal carotid bifurcation and the middle cerebral artery in the circle of Willis. The peripheral cortex is said to have a pale infarct appearance. Now, with embolisms, most often the source is the left side of the heart, and this is due to atrial fibrillation. And this embolism travels to the middle cerebral artery. The periphery of the cortex, as opposed to being a pale infarct, would be a hemorrhagic infarct. Other sources of emboli include paradoxical embolism, and this is due to a patent foramen ovale, or very rarely, the embolism could be due to air, fat, or tumor. And here is just a simple diagram showing the difference between a thrombotic stroke and an embolic stroke. Notice here that the thrombotic stroke occurs at the bifurcation, and the embolic stroke is much later on. Now, the last subtype, lacunar, is linked to hyaline arteriosclerosis of small vessels, specifically lenticulostriate vessels. Now, this is due to hypertension, and this results in small cystic areas of infarction. If the internal capsule is involved, this will result in pure motor stroke, and if the thalamus is involved, this will result in pure sensory stroke. So now I'll talk about hemorrhages, and we'll put ischemias to the side. First, we have intracerebral hemorrhages, of course located in the brain parenchyma, and this is due to, for example, rupture of Charcot-Bouchard microaneurysms of the lenticulostriate vessels, and so the basal ganglia are often affected, and hypertension is of course the cause, but essentially it's the rupture of any parenchymal vessels. Now the results would be nausea, vomiting, a severe headache, and eventually coma. Subarachnoidal hemorrhages occur in the subarachnoidal space. 85% of the time it is due to a Berry aneurysm, and 15% of the time due to arteriovenous malformations and use of anticoagulants. The patient says that they are experiencing the worst headache of their lives, also known as a thunderclap. They have nuchal rigidity, and upon laboratory findings, xanthochromia, bilirubin in the cerebrospinal fluid, will be identified, and other causes of subarachnoidal hemorrhage are linked to Marfan syndrome and adult autosomal dominant polycystic kidney disease. Here we have two images. On the left is intracerebral hemorrhage, and on the right, you will see subarachnoidal hemorrhages. And here we have four types of brain hemorrhages: epidural hematoma, subdural hematoma, subarachnoid hemorrhage, and intracerebral hemorrhage. I believe epidural hematoma and subdural hematoma will be covered in traumas, but I have now covered subarachnoidal hemorrhage and intracerebral. Next, we'll be discussing degenerative disorders. Now, what is it? Well, these degenerative disorders are the destruction of myelin surrounding the neurons, or myelin producers, and of course this is in the white matter. Now, just a reminder that oligodendrocytes are in the central nervous system, and in the peripheral nervous system we have Schwann cells. All in all, the axons are preserved. Now, examples of degenerative disorders include leukodystrophy, multiple sclerosis, subacute sclerosing panencephalitis, progressive multifocal leukoencephalopathy, and lastly, central pontine myelinolysis. Now let's talk about leukodystrophy. This is an inherited enzyme mutation that will lead to poor myelin production and maintenance. And the variations include metachromatic leukodystrophy, which is autosomal recessive. This is the number 1 leukodystrophy, and it is the deficiency in IL-sulfatase. There is no myelin degradation, so accumulation of myelin in the oligodendrocytes lysosomes will occur. There is Crab leukodystrophy. This is also autosomal recessive, deficiency in galactocerebroside, B-galactosidase, and accumulation of galactocerebroside in the macrophages is cited. And lastly, adrenal leukodystrophy. This is an autosomal recessive but X-linked, and it is because there is an inability of coenzyme A to be added to long-chain fatty acids, and hence they will accumulate and damage the adrenals and brain's white matter. So now we'll discuss multiple sclerosis. Now this is of course a very important disease for us all to know. It is an autoimmune disease, therefore it is most often found in women. It is the CNS destruction of myelin and oligodendrocytes. The gene associated with MS is HLA-DR2, and in order to treat acute attacks, you administer high doses of steroids. And in the long term, instead, you will give interferon beta, which will slow the progression. The diagnosis can be conducted vis-a-vis MRIs. With it, you will identify plaques, which are white matter degenerations. You can also conduct lumbar punctures, where you will cite lymphocytes, oligoclonal IgG bands, and myelin basic proteins. And lastly, on gross exam, you will see gray plaques in the white matter. Now, it's really important to know the clinical features of multiple sclerosis, and I know I myself struggled with this a lot, so I found this image on the internet. As you can see, the patient often has tinnitus, hearing deficiency, nystagmus, diplopia, blurred vision, dysarthria, dysphagia, etc., etc. And the onset is usually between the ages of 20 to 40. The weakness of the individual may progress to paralysis, and the patient often has bladder problems and constipation. Now here we have subacute sclerosing panencephalitis linked to the measles virus, and it is a progressive disease that often results in the patient's death. The measles virus infects the patient's brain, and the infection occurs during the infantile stage, and the signs will only develop in childhood. How do we identify this? Well, we cite viral inclusions within the neurons and oligodendrocytes. And here we have progressive multifocal leukoencephalopathy, also known as PML. As many of you, if you've watched Sketchy, will recall, this affects immunosuppressed individuals, for example, those with HIV/AIDS. And the virus is the JC virus, and what it does is that it infects the oligodendrocytes, which will then result in the patient's death. Clinical features of PML include visual loss, weakness, dementia, and it is rapidly progressive. Central pontine myelinolysis is quite frightening. It is the focal demyelination of the pons, and this is due to rapid intravenous correction of hyponatremia. With hyponatremia, we have low sodium in our blood. If we try to correct this by giving a lot of sodium rapidly, what would happen is that all the water would leave our cells and enter the bloodstream, and so the pons will be dehydrated, i.e. demyelinated. This is cited in severely malnourished patients, and the clinical features would be that the patient is essentially locked inside of their own body. It is only their eyes that are able to shift around, and hence it is called locked-in syndrome. Now we'll talk about dementia and degeneration. This is in the gray matter of the brain, and it is the accumulation of protein that will actually damage the neurons. If it is in the cortex, this will result in the patient's dementia. If it is in the brainstem and the basal ganglia, this will affect the patient's movement. Examples of dementia and degeneration are Alzheimer's, which is number 1, vascular dementia, Pick's disease, Parkinson's, Huntington's, and spongiform encephalopathy. Alzheimer's is of course very common. In 95% of the elderly, it is sporadic and the risk increases with age. It is linked to apolipoproteins, although the pathophysiology of Alzheimer's disease is not fully understood. There are 3 hypotheses linked to it. One would be the deficiency of acetylcholine, another would be due to apolipoprotein, and another one is, I believe, due to beta amyloid plaques. The morphology of Alzheimer's disease, well, there are active plaques and there are inactive plaques. With active plaques, there's ongoing myelin breakdown with sharp demarcations, and overall there is inflammation. In an inactive plaque, the inflammation has disappeared. There is a loss of myelin staining because there is no more myelin, and there is reactive gliosis. The clinical features of Alzheimer's include progressive memory loss. It starts off as short-term memory loss, progresses into long-term memory loss. There is also a loss of learned motor skills and languages. There is a personality and behavioral change, and the patient is mute and bedridden and often susceptible to infections. And here we have Parkinson's disease. Now, Parkinson's disease is a dopamine deficiency in the nigrostriatal pathway. The etiology is unknown. 2% of the elderly are affected, and the end result usually is dementia. Now, the clinical features, there's a mnemonic to help you, and that's TRAPS. Tremor, rigidity, akinesia, postural instability, and shuffling gait. And the loss of pigmented neurons in the substantia nigra is often cited. And quite often, there are Lewy bodies, which are round eosinophilic bodies of alpha-synuclein in the affected neurons. And here we have the disease symptoms. Often you will notice a stooped posture, a shuffling gait, and a tremor. Now I'll talk about Huntington's disease, which is the degeneration of GABAergic neurons in the caudate nucleus. It is an autosomal dominant disease found on chromosome 4, containing CAG repeats or CAG repeats, and these are multiplied in the Huntington gene. Now, a common occurrence cited in Huntington's disease is anticipation, which is an earlier appearance as generations progress, and this occurs particularly in spermatogenesis, for example. Patients have chorea, which is to dance in Greek, and that can progress to dementia and depression. The average age of onset of Huntington's disease is 40 years old, and the death of the patient is most often due to suicide. Next, we have vascular dementia and Pick's disease. Vascular dementia, which is number 2 right after Alzheimer's, you will see multifocal infarctions, and this is due to hypertension, atherosclerosis, and there, of course, you will note down vasculitis, and eventually the patient will have dementia. In Pick's disease, there is a degeneration of the frontal and temporal lobe, and quite often the parietal and the occipital lobe are spared. On a microscope, you will notice Pick bodies, which are round aggregates of tau proteins in cortical neurons. The patient will have behavioral symptoms, language symptoms, and eventually they will have dementia. And here we have spongiform encephalopathy. It is a degenerative disease, and what we have are disease beta-plated prions. Now, prions are just proteins on the cell surface membranes. We all have normal configurations, but people with this disease have a disease beta-plated configuration. It's misfolded, and this can either be sporadic, inherited, or transmitted. How may it be transmitted? This may be through human growth hormone or a corneal transplant, and perhaps through cannibals. That is an example I'll leave till the end. And PRPSC is not degradable. In fact, what it does is that it converts normal prions to the diseased prions. So it's a vicious cycle. And damaged neurons and glial cells eventually will contain intracellular vacuoles, and this is why we have a spongy look. First, we have Creutzfeldt-Jacobs, which is the #1 spongiform encephalopathy. It is often sporadic. It is a rapidly progressive dementia with ataxia and startle myoclonus. What is startle myoclonus? Well, it is the contraction of muscles despite there being a stimulus. You will notice EEG spike wave complexes, and the death of the individual is in less than a year. A variation of Creutzfeldt-Jacobs is variant CJD, which is due to exposure to bovine spongiform encephalopathy. This is also known as mad cow disease. Family fatal insomnia is another example of spongiform encephalopathy. It is inherited, it is linked to severe insomnia, and an exaggerated startle response. Next we have Kuru, which means shivering, and this is located in the highlands of New Guinea. It is very, very rare, of course, and it is linked to cannibalism. Now, individuals with diseased prions, once they have been ingested and consumed by normal individuals with normal prions, the diseased prions will go forth and convert all the normal prions into diseased prions, because prions that are diseased cannot be degraded. And how will this present in the individual? Well, the person will have cerebral ataxia and their death will come to them in less than a year.